Thank you so much for having me. I'm so honored to be here. I can tell you that I watch these lectures all the time, and I've learned so much from them. So I'm really honored to be invited here. So I wanted to, once I was invited, I knew I wanted to speak on this topic because when I was a graduating fellow, I was envisioning what my life would be like, once I was out on my own. And of course, I do have senior mentors at my institution, and I'm lucky to be able to ask them to help me in the operating room. But not everyone has that luxury, and so I think it's really important to be totally prepared, or as prepared as you can be, before you get into that setting, because when you get your first or second or third or fourth intraoperative complication, you're going to feel pretty alone, and you want to have some preparedness for that. So again, we all make these preoperative plans and try to think about, what's my ideal? How's it going to be? I'm going to get this case done in 30 minutes. It's going to be great. But that does not always happen, especially as we start out. You have to understand that things change in the operating room, and they can change very fast. And when that happens, it can be very distressing. So I'm going to go over kind of some of the things that I've found most distressing or that I want to be most prepared with. But there are other things on here. If you're doing a lot of laterals or prone laterals, you also want to be thinking about like colon injury and things like that. So what I would recommend, honestly, is you can ask me. I'll email you this talk, and I have a longer version of it. And also make your own list. So you're prepared before you go in there, so you have at least a rough idea of what you're going to do if one of these horrible things happens. So I would say actually the most important part is really your psychological state if something happens, and that begins outside of the OR. Once something bad happens, it's a natural human reaction to be stressed, to be anxious, to change your demeanor, and that affects everyone in the operating room, as Dr. Skaggs spoke about earlier. So you really want to be sure that your decision-making can be as calm, as collected as possible, and that comes from having some kind of mental preparedness and some type of essentially baseline stoicism before you get into the OR. Preparedness helps me a lot in terms of reducing my anxiety. You know, for example, how much blood you've got, if you're at an ASC, if you can get a vascular surgeon there at all, and the checklists are prepared so people know sort of where to start with. And again, really in this field, it's important to know that things are going to happen and be as prepared as possible to just deal with it and help do for the patient what you can. So intraoperative complications do tend to be less frequent than postoperative complications, luckily, but they have a high morbidity and mortality. So again, prevention and anticipation are critical. Checklists are immeasurable aids in terms of this. It's been shown over and over again in terms of reducing complications, morbidity, mortality, and you really want to use these because they help you adhere to those steps that you might have forgotten or might miss over in your panic. So this is something we're doing at our institution. I hope many of you are as well. This is the safety sign-in, which is different from the timeout. It's, again, has been shown to lead to great reductions in morbidity and complications themselves. And essentially, this is where you get into the operating room with the patient awake and you talk about the case, what you're going to be doing, and then that's separate from the timeout, which is right before incision. So where I trained in fellowship, what we would do during this safety sign is we'd go over the length of the surgery. Are we talking about a 6-hour case or an 18-hour case? We talk about different times when you want relaxation and paralysis versus when you need to be doing EMG. So if you're in lateral position, for example, you're going to want something different for a lateral A lift than you are for an X lift if you're going through the psoas. So it's important that everybody is on board because you can really only reverse once. Expected blood loss, and when is the EBL? Is it going to, especially in tumor, once you're in the tumor, that's when things start going pretty quickly. So anesthesia needs to know the blood needs to be in the room at this amount of time. MAP goals, this is for correction or myelopathy surgery. As Dr. Skaggs mentioned earlier, you want to have it relatively low for the exposure if you're doing one of these big whacks. But if, again, someone has myelopathy and you're doing decompression, you're really going to want it higher or if signals go down. And then TXA use is something I use all the time. You want to make sure that anesthesia is on board with you there. So up here, this is an algorithm used for preoperative planning, and I'd recommend you have your own if you can, if you're doing, sort of intense deformity surgeries. For the long cases, the big cases, talk about it ahead of time. Don't just go in alone. This protocol has dual attendings, which is always great if you can get it. Discuss it in preoperative conference. Understand what you're going to do in the event of intraoperative coagulopathy. Make sure you have the blood available. I use TXA for everything. Understand your transfusion thresholds. For me personally, I get labs every hour, and I transfuse for hemoglobin less than 10 in the OR. If I'm doing a big case, you just want to be safer in the OR, and they're going to keep bleeding, putting it out through the drains post-op. Aquamantis, bone scalpel, controlled hypotension, all things that have been demonstrated to decrease blood loss and need for transfusion. And then again, keep track of how much blood you're losing. It can go pretty quickly, and you don't always know how on top of it anesthesia is. So you're ultimately the surgeon. You need to be on top of it too. Okay, so the injuries. Great vessel injuries happen, hopefully not to you, but you need to be prepared in case they do. This is something we can look at in the labs, exactly how close they are to the ventral surface. But L4-5 and L5-S1, those iliacs are right there in front of it, especially in a revision setting. You can get into this from the back, obviously the front, but if you're doing a TLIF or something, that can be really scarred in. So L4-5 most often kind of nails that left iliac. So you want to be careful to that. And then aorta and vena cava are more commonly injured a little bit higher up. So if this happens to you, it might not always be clear that it's happening because the blood doesn't always pool directly into the field. What can happen is that the ALL is actually pretty elastic. So if you're in the back and you just sort of nip something like with the pituitary from the front, you might not see the blood well up. It might actually be kind of tamponaded in the retroperitoneal space. So you really want to have a high suspicion if you see that the patient suddenly becomes persistently hypotensive and tachycardic in spite of sort of resuscitative efforts, even if you don't see a lot of bleeding. Again, young people as well might not even have these physiological changes until they've lost 40% of their blood volume. So what do you do in this case? This is the checklist I have. Again, I keep this sort of on my Google Drive, so God forbid I can always pull it up. Pack with hemostatic agents if you do see the blood welling up, and just hold it there. Pressure and hemostatic agents are what you want to do for blood loss, not suctioning. Let anesthesia know, like something's not right, we think there's a problem, just get ready, get some IVs in. You need to know who to contact. So if you're at an ASC, you might not necessarily have like blood there. You might not necessarily have a vascular surgeon who's credentialed there. So you really need to understand what your resources are before you sort of get into this situation. If you're in a lateral versus posterior, there's sort of a different kind of branch here, as you can kind of access the vessels pretty well from the lateral side. But if you're in posterior and you think this is pretty real, you got to be ready to flip. Just close it up, staples, IABAN, and be ready to flip. You do want to be on a radiolucent table because IR at the very least can sort of stent something, put a balloon in there and tamponade if it's taking long for vascular to get in and help you. So you want to make sure that they can do their imaging through that. So that's kind of the first step, and then hopefully IR and vascular can help take it from there, because I'm certainly not trained in these repairs, and they are not easy. Vertebral artery injury. This is more common, I'd say, than the great vessels. The most common time that it's been cited in literature is those C1-2 screws, which we were alluding to earlier. I don't think we're doing as many of those, and it's much safer now with NAV. But you can still, this can still happen. I've certainly seen it, and the immediate problem is really the actual exsanguination, essentially. It's a very high-pressure artery, and so that's the number one thing that you need to get under control. So number one is that. Second is immediate vertebrobasilar ischemia, and then kind of all the sequelae complications are third step. So number one, again, direct tamponade. You don't, in this case, want to be putting gel foam thrombin, you don't want to be putting Surgiflow or anything that can embolize through the artery into the brain. So you really want to do gels, patches, things that are just going to like stick on top, get it under control. Once you have hemostasis, then you can start sort of thinking about what the next steps are. So this is a nice algorithm from the paper that was referenced in the previous slide, where it essentially walks you through, is the bleeding controlled? Yes or no? If it's not, essentially keep going, or you can have endovascular. You can take them into this suite there. The better alternative is actually to bring endovascular into your OR, because frankly, if you go to the IR suite, you're not going to have the same intraoperative tools to fix it. So it's better, they will complain, and it's difficult to do prone because they need to access the femoral structures, but it's way better to do that in a real operating room and then bring their wires in than you go to their suite than not be able to operate there. And again, if you can repair it, that's ideal. I'd recommend getting vascular surgery to help you with that. It's pretty difficult. Some of our neurosurgery colleagues have experience doing this with their fine motor skills and whatnot, but it's a pretty small vessel, so difficult for me. But again, if that fails, then you can also ligate it typically, especially if you've already done the IR situation, so you know that there's collateral circulation. That works out for most people, but you need to know ahead of time. If it's their only vert, you better try to save it. Esophageal injury is pretty infrequent, and it happens most often postoperatively rather than intraoperatively, but if you do recognize it intraop, you have to fix it then. You can't just say, we'll come back later, because the sequelae of this can be disaster. You can use a contrast dye study where they put it through the NG tube or in the esophagus and just see if it leaks out. But if you identify it and you see it leaking in there, you got to get ENT to come over. They say that they use the SCM most commonly. I personally try to leave the omahyoid whenever I can, because I've been told by my ENT colleagues that that's a good flap for that. But you're not looking at kind of one quick repair if you don't get it the first time. So neurologic injury, this is something you probably will see at some point in your career, probably the most frequent issue that we have. So you got to have intraoperative protocols to know about this ahead of time. If for nothing else, this is one of the more high-frequency things. So talk about the patient comorbidities, positioning, intubation, glide scope, and know that you need to keep your map up. Does neuromonitoring help? Unequivocally, yes. Certainly at the cord level, certainly for deformity. You've got to be multimodality, and I would argue honestly, and it depends on your market, but if you're in a court of law and you have access to neuromonitoring, even at, in the lumbar spine instrumenting, and they ask why didn't you use it, you better have a good reason not to if there's a problem. So there are a number of different studies and checklists on neuromonitoring. I think it's important to kind of recognize what you do and which checklist applies to you. But in terms of what matters, SSEP drops over 50%, that's meaningful. If it's something less than that, or they say, oh, we've got a drop in something, I always have them quantify it. I don't want to hear, oh, it's down. I want to hear what percent it's down. And like I think, again, Dr. Skaggs was saying, they tell me we've lost signals. I say, where specifically, tell me which nerves you're monitoring, which muscles you're monitoring, and what percent it's down. And then I go from there. In MEP, the threshold is really variable. I use at least 50%. In Japan, they use a little higher. And again, that's different at the cord or root level. It's much less sensitive at the root level, unfortunately. But in general, you do want to consider all alerts real until proven otherwise. Your checklist, whatever one you decide it should be in the room, readily accessible, and everyone should be familiar with it. This is kind of the standard one that's used, I think, most commonly with a stable spine. I like to use this one for my deformities because it helps me break it down into sort of more granular details. It's very different if someone has neuromonitoring changes once you flip them in position, you haven't even started, versus once you've closed an osteotomy, versus if they're off the table, and in the ICU and they wake up and they can't move. So this one kind of breaks it down nicely. And interestingly, as time has gone on, I guess, these days, it seems like we kind of get these changes and we respond to them. Historically, people, I guess, would, they'd get a change and then say, like, this is it, call it for the day. I think if I've seen a lot of times we'll get a change, we'll respond to it appropriately with the maps and maybe less correction, and, everything will come back. And in that case, it's okay to proceed. But if things are kind of dicey, you keep losing signals, whatever, then, you can always close up and live to do it another day. Dural tears, you will definitely encounter this in your time as a spine surgeon. And it's just important to know how to fix them. Unfortunately, it's tough in a cadaver, and this is a very different skill set than the other parts of spine surgery, but you gotta know how to fix it. So that paper was a JAOS review, and essentially what they recommend, which is pretty much what I do, is try to get that watertight closure the first time. There's no demonstration of superiority in any type of material. I use Gore-Tex because the actual suture is bigger than the needle, so I feel like it plugs the holes, but a lot of my neurosurgery colleagues like Neurolon. And then over that, a patch. It kind of doesn't matter which one you use, and then glue. You want to check with the Valsalva after, and I think honestly the most important part really is the tight fascial closure. It's got to be just 100% not leaking through the fascia. Can't leave your resident to do it. You've got to do it yourself. Drains are safe. I keep them to gravity. If you have a chest tube that's in continuity with the tear, it cannot be to wall suction because you can't have any chance of the CSF going to wall suction. That it would kill the patient. Bed rest is somewhat controversial. I'm doing it less and less, certainly not for MIS, I just send them home. But if it's a big one or they're already down for deformity anyway, it's sort of risk-benefit. So repairs with collagen matrix actually have a 95% success rate using kind of onlay only, and again, that's probably due to the fascial closure. If you do get something that's totally irreparable, you can try to take some fat, which is a nice hydrophobic material, and so it can you wrap it around the dura, and that can be a nice thing to kind of keep the CSF in while everything is socking down. The lateral patch technique has been described by a number of different people, but essentially if you've got something ventral or somewhere you just can't get to it, you can't take any more bone to get to it, you can make a midline durotomy and then tie a piece of fat to it and then pull it out through the durotomy and then anchor it somewhere so it's sort of like a plug from the inside out. Me as an orthopedic surgeon, I probably wouldn't do this in a primary, but for a revision setting, I'd try it or certainly try to rope one of my neurosurgery colleagues into helping me. So when these are properly treated, most literature says that there's really no difference in terms of outcomes. However, they are a very common cause of malpractice lawsuits. And so you have to, one, inform the patient, tell them this is going to happen, give them a high, this could happen, give them a high probability. I usually quote 7% in primary surgeries. And then when it doesn't happen, I say, oh, great, you got lucky. But they know about it coming in. It's not the first time they've heard of it. And then cervical ones, the anterior, can be very, very difficult to manage. I've seen this once, and what I would do in the future is basically place a lumbar drain pretty much immediately after, because once it starts coming, it's very difficult to access that area, so you're going to have a hard time with a direct repair. And then once it starts coming out and creating a pseudomeningocele in the neck, that's a very challenging situation. And then in terms of bed rest, you want to have them upright post-op rather than supine to decrease the hydrostatic pressure in the cervical spine. Wrong level surgery is something that we don't talk about a lot because it's pretty distressing, but it happens and it's important to know it could happen to you. So this is when there's an unintentional deviation from the plan. It doesn't necessarily mean that any harm was done to the patient, but it does mean that there was a deviation from the plan. And in most states, this is reportable. So in a survey of the AANS, 50% reported that they had at least one wrong level surgery in their career, okay? And 10% reported 4 or more, which, that's another issue. But it happens, especially in the thoracic spine, up to 2%, and some studies cite even more. So it's really important to have x-rays. I get Scoli films on all my patients. You'd be surprised the number of people, 13 ribs, 6 lumbar vertebrae. It's really important to know where you go. But just in terms of like making a quick cognitive error, you've got to do the timeout. You've got to have your images up in the room. You've got to compare it to the pre-op, have it visually. If you don't have screens in your room, have it printed out somewhere. You just don't want to be the person making this mistake. And then a couple of us have sort of alluded to human error management and prevention in other fields and how they do it better. But you want to have an environment where you can ask anybody in the room, like if you see a problem, you've got to say something. And then asking an open-ended, non-leading question is going to get you a more honest answer from someone who views you as a superior than asking, hey, is this L4-5? You say, what level is this? And then you both come to independent conclusions. Cage misplacement. This is another thing you don't see often, but it happens. Again, this is a review of 12 cases, and interestingly, 3 were able to be removed during the case, which I wouldn't necessarily recommend, and I've seen this too, but if you can kind of grab it, go for it, but only if you can really see it. Do not go poking around from back to front, like just in there. But going in there retroperitoneally can actually lead to some really adverse events. So if it's just floating there and it seems pretty safe and vascular, think it's safe, maybe think about just leaving it. So in summary here, we're not in a low-risk field, but when you're in the operating room and you're alone, it feels very different than when you're in training. So in terms of being prepared, you need to know the kind of dangers that are out there and have a plan in case any of them happen. Thank you.
Really cool. Thank you, Liz. Let me ask you a very sensitive question. For a younger attending, do you feel more focus on you, given all the administrators and whatever surveillance systems that they have now for quality improvement, whatever they define that as? Do you adjust your practice to kind of respond to that preemptively? What is the experience of a younger attending in this new era?
Yeah, that's a really good question. I will say that, I do a lot. From the beginning, have done a lot of pretty big, high-risk, high-complication surgeries, and I think you have to, run towards your complications. If you have a whiff of anything, you need to figure out if it's real and then respond to it with full disclosure to the patient immediately, because it's not, complications happen. They're going to happen to everybody. That's sort of not the problem in my mind. The problem is or the problem can be how you respond to it. So I think, full disclosure, full transparency, just treat it the best you can. And, in my experience, patients have been responsive to that. And the administrators, they have to get it. This isn't, we're not baking cakes here.
Liz, great talk, and lots of topics covered, and a couple of kind of caveats that I would just tell the young surgeons is that you can stop bleeding pretty easily. It really doesn't matter how big it is, and especially it's something like a vertebral artery. Just a little personal experience. I remember I had a fellow that I did a case down at Santa Monica when with UCLA first bought the place. He's a great surgeon, turned into a great surgeon, but he turned a curette out into the vertebral artery. And of course, the whole wound filled up with blood. So you just took a sucker down there. I've seen it a couple other times, unfortunately, but a small, but not too big and not too small piece of gel foam will solve the problem. It's really simple. You can't repair it from inside of this, when you're doing a discectomy operation or something like that. And it's almost the same thing. I've seen and probably dealt with almost every complication that exists. In fact, I have of every one of those, including neurologic problems of varying degrees and anterior CSF leaks and things like that. Probably the most important thing is think about who's going to help you. Yeah, that's the most important thing. I mean, if you have a vascular problem, in the modern era, we have endovascular people and IR people. They're your best friends. Your other best friends are things like CSF leaks. I don't think there's such thing as an unsolvable CSF leak problem. No matter what, most of it, just to kind of go into that a little deeper, is that most of them happen in redos. Most of them happen posteriorly. And so those are all actually accessible. And so it just takes mobilizing, getting dural edges back together in most all cases, and things like grafts. I mean, you can do that. You could, so you have different graft technologies, but, small sutures, okay? I'm not a Neurolon guy. I grew out of Neurolons about 20 years ago because I don't like the suture and the needle and the thread, and they're not a precision tool to me, at least in my experience in the hands. So use something small like you do with Gore-Tex or Prolene, little tiny sutures that don't put holes in the dura, mobilize dura, things like that, and deal with the problems. Make sure that you know what's happening if you lose motor evoked potentials or somatosensory or something. You have lots of friends. Use them all. And that's the message to all of these young surgeons in the room here.
I think that's so important, networking and having client of friends here. Talk to us, if you will, about emotional impact of complications. Again, you take on very big cases. You're an amazing surgeon. You have a great communication skill. But what happens inside a surgeon when you have that first, oh my God, complication? Any general tips? I mean, I think we just heard a great one, networking, talking. But talk to us about how you handle the emotional impact. What are some thoughts for young surgeons as they go out?
I mean, one, I think having the training, kind of when you have these events happen in your training, to really sort of see what your mentors are doing at the time and write down how they're handling it, and then also maybe talk to them about how they're handling it emotionally. I had a mentor who said, and at the time I didn't really get it, but he was like, you know what, no matter what happens on the table, like, I'm not gonna die today. And at the time I was like, that's a little callous, but now that actually helps me a lot. I'm like, sometimes bad things happen, but you do have to separate that from either how you're going to manage that patient or how you're going to take care of all the rest of your patients. So there does have to be some kind of separation there. And I really think you can only get that if you feel like, you're prepared for the case, you're doing your best. That's the way you can sort of sleep at night. Even if you do all those things and something bad still happens, then you've done what you can do. I think Dr. Skaggs.
Dr. Lord, that was an amazing talk. Congratulations. If I can share, thinking of things ahead of time, I once nailed a iliac vein. That could be a really bad day. Quickly flipped the kid over, applied pressure for 20 minutes. That was it. Didn't need a repair. So anytime you have bleeding, as long as you're not next to a cord, just think about direct pressure. Most bleeding stops that way.
There's a question in the back.
Who else? Yeah. So wait, I'll give you a microphone. Yeah, a microphone.
Thanks, Jens. You showed a great talk, by the way. You showed a couple of papers talking about kind of dual surgeon approaches for big surgery. and there's a lot of data for that. But I'm curious, there's a room of fellows. How do you incorporate then teaching fellows, residents who are going to have to go out and do this? How do you sort of manage that if you're doing a dual surgeon approach?
Yeah, I think that's a great question, and it's great if you can get it. I'll be honest, I don't get it very often myself. I insist upon it, and I won't do it else for sacrectomy, en bloc, spondylectomy. There are times when I just won't do the case unless I can get it. But for my deformities, I'm not using it. I think if you're in a teaching institution, that is a named goal of the institution, and so you might have to compromise a little bit there, because the goal is to send you guys out into the world prepared to handle the stuff on your own.
Any other questions? Otherwise, oh yeah, sorry. Let me see. Tell us your name again.
My name's Kareem. Thanks for that talk. Excluding your deformity cases, what is the extent of your preoperative discussion with patients with regards to risk to surgery? I know you mentioned you give them a number for dural tears, but when you're doing anterior surgeries, do you tell them about these risks and what could happen, especially early on in practice?
Yeah, so I actually do, and it's funny because I told another fellowship mentor, Themi Protopsaltis, that I was, going to walk patients through. I am like very kind of extreme in terms of preparation. But I was like, I'm going to tell everybody sort of every risk I can think of. And he's like, that's going to kill your practice. Like you won't be, you're in LA, you're not going to be able to practice that way. But it hasn't really. I think patients actually, some of them don't want to hear it. But if you're honest with them, you say these things can happen, C5 palsy. If someone doesn't know what that is, they have to know what this stuff is, so that when it happens, they're like, I have heard that before. Because otherwise, they're going to think you did something wrong. Versus someone, C5 palsy, totally weak, not hand to mouth, like, you said this could happen, I'll wait it out. So I think it's, over-prepare and hope for the best.
Let me just add something to that. Nowadays, cut and paste. So I have a lot of friends in the med mal world and some enemies, but cut and paste in medical records is a big problem. Any advice of how to avoid that? Because all of us can kind of hit a little smart face thing and it prints out a beautiful thing. Any things to avoid, and how can we make sure that this kind of resonates with a hostile secondary or tertiary review?
I think there's studies that demonstrate that IMED consent, the sort of pre-made online consents, that sort of lists the risks. Doing those decreases your risk of a verdict against you in lawsuits, and then also doing the consent not on day of surgery, but in a preoperative setting where the patient has time to sort of go over it and mentally marinate. Those are my sort of early career thoughts. I'm sure you guys,
It probably only takes less than 5 minutes to actually have the conversation and list all the risks. The copy and paste, you're right, there's all kinds of issues. But if you have documented that you had the discussion and the conversation and you listed those, and it takes 3 to 5 minutes for every case, it's well worth the 3 to 5 minutes to avoid getting sucked into a little lawsuit when some bad things are going to happen. They're just going to happen.
Dr. Johnson wants to say something before Dr. Screen has an announcement. Please, Dr. Patel wants the questionnaires back. Thank you for helping. Yeah.
So along the lines of informed consent, and I have also represented a lot of people, and including some plaintiffs as well that really need to have something rectified. But I defend most people when I review medical legal cases. But I think it's important to remember that there's no such thing as informed consent. Okay, there is nobody that knows everything about everything that can happen in any operation unless someone is an ultimate expert in that field. So how I think some of that's dealt with, and I can tell you at my stage of my career, I can do this. I look at patients and I know where there is a potential. If I'm operating on somebody's C5, I'm going to focus a little bit on that. But as you just heard Richard say, the less time you spend, sometimes the better, because people ask, they say, what are the complications? I say, well, common things are things like infection or something, or you're still going to have pain. I said, the worst thing is you can be paralyzed or dead. And it's true. Anything in between that, and I even say it that way, I say, and there are a zillion things in between. This is just full disclosure. What's the worst thing that can happen? I've been doing a big front-back operation, I can kill you. Has that happened? No. So, just be open with your patients. And then when they do have something wrong, I'll say the biggest problems are the ones that have an infection. It's like, why do I have an infection, Dr. Lord or Dr. Johnson? And I say, well, nobody wants one. You didn't. It just happens. I had one patient one time just start yelling at me, and one of my young surgeons, who's not so young anymore, still remembers it. And I told the patient, I said, "Why do you have an infection?" "God spoke." Patient made a complaint, and I said, "It's okay. I'll own that complaint too." But anyway.
All right, so please hand in great lecture. Thank you, Liz. So please hand in the questionnaire.